Bismillahirrahmanirrahim. I'm Dr. Abdulaziz Hazazi, a consultant of pain management. My talk for today is pediatric pain management in emergency department. My outlines for this talk will be as follow. First, we'll give brief introduction about pediatric pain management, and then we'll go over the challenges that we are facing usually for this type of patient, and then brief physiology and pain pathway, including definition or new updated definition of pain in general. And then we'll talk about consequences that we are facing usually of not treating or under treating pain. And at the end, we'll go over pain assessment scales, the commonly used scales, and evidence-based strategies, and we'll go over some scenarios that we are commonly encounter in emergency department. So adequate analgesia is critical and very important, and can be challenging most of the time for this type of patient. Suboptimal treatment of pain can have deleterious effect in the short term, and it can also affect the patient developmental and reaction to future painful experience. That's why we are very concerned about treating pain in this type of patient. Because of a relative lack of inhibitory neurotransmitters and large receptive field and an increased concentration of substance P receptor, it is theorized that infants may feel pain more severely than older people. Treatment of pain, not only pharmacological but also non-pharmacological methods, can be effective in the management of pediatric pain. And emergency clinician must remain vigilant in the recognition, treatment, and reassessment of pediatric pain, as this patient developmental level may limit their ability to independently express their pain experience without promoting or without any tool. And the quality and location of pain may alert the emergency clinician to the presence of a disease process. Addition to that, pain is a frequent and most of the time is a preventable side effect of many of the diagnostic studies and treatment performed in emergency medicine, like intravenous cannulation and close reduction and lumbar puncture. And that's very, very important to consider when treating this patient. If we go back to the history of pain treatment in pediatric population, we'll go back to 1968. They were saying before seldom need medication for relief of pain. They tolerate discomfort well, and still, unfortunately, some of clinicians or doctors practicing this till now. Many cardiac surgeries done without analgesia for neonate, and numerous studies done in 1980s quantitatively demonstrated a pronounced lower usage of analgesic for definitively painful condition in children versus adults. Studies from 1990 documented this phenomenon in emergency department, showing that children receive analgesic significantly less frequently than adults in compare when presenting with same painful condition. In 1997, in a chart review of patients with a long bone fracture, although 73% of adults receive analgesic in the emergency department, only 53 of children did receive. In 2017, in another chart review looking at children diagnosed with appendicitis, 40% receive no analgesic at all in the emergency department. Of this slide to review the definition of pain by International Association for study of pain published 2020. It There is no significant changes, but now they call it an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it is multifactorial, not only pain itself, but it includes physical, psychosocial, emotional, cultural, and contextual. Here the list of common challenges that we are facing when dealing with this type of patient. Pain is usually subjective, self-reported in pediatric group, especially the small pediatric. They will not complain of pain. Optimum pain management is lower in priority of busy emergency department, and this is not always true. Qualifying and quantifying pediatric pain difficult and can reduce their ability to advocate for treatment of their pain. Unfounded concern from both emergency clinician and consultants regarding masking pain and interfering with accurate diagnosis may lead emergency clinician to under-treat pain. Number 5, the concerned emergency clinician and patient family have unclear potential for addiction. In the other hand, why I do need to treat pain? The relief of suffering is one of the fundamental goals of medicine, and because an adequate treatment of pain increases pain satisfaction, and despite long-standing myths, all patients, including neonates, feel pain, and there is convincing evidence that exposing young patients to painful stimuli can have both short-term and long-term consequences. Back to the basic physiology of pain. The physiology of pain is the response. The physiology of pain response is complex and multifactorial. Usually, depend on patient age and past experience, personal and family beliefs, culture and genetics. These usually some important factors that affect the final perception of a single painful stimulus. Pain pathway also demonstrates significant plasticity. Unlike other processes, exposure to painful stimuli result in upregulation of pain pathways and potentially leading to pain hypersensitivity, with this effect being greatest early in the early life of this age. This, to summarize the pain pathway, we have 4 components usually: transduction, transmission, perception, and modulation. Here in this picture, we are showing the type of some analgesic, including pharmacological and non-pharmacological for each one. For example, transduction usually relieved by ice, and elevation, local anesthetic, or splinting can help. Transmission is the standard oral relief by standard oral, intranasal, or IV analgesic, while pain perception can be relieved by distraction, reframing, and other non-pharmacological techniques. And the sum of all these effects or efforts encourage pain modulation. What are the consequences of pain in infants? There are different immediate, short-term, and long-term. Immediate effects usually like irritability, fear, disturbance of sleep and wakefulness state, increased oxygen consumption, ventilation, perfusion mismatch, diminished nutrient intake, and increased gastric acidity. Some short-term effects like enhanced catabolism, altered immunological function, delayed healing, emotional bonding, while the long-term usually happen after sustained pain for at least 3 months, like memory of pain and developmental retardation, alteration in response to subsequent painful experience, and this usually causes fear of pain in the future. Assessment of pain in pediatric group. Usually we have more than one scale to use. It depends on the age group. For example, in 2 months to 4 years age group, we have what called faces, legs, activity, cry, consolability, flag scale. Initially developed to evaluate post-operative pain, and some evidence to support its use in acute pain and procedural pain may not distinguish pain from anxiety, and that's disadvantage of this pain scale. After that, in 4 years and to 12 years, you have commonly used faces pain scale. This is the revised one, and we'll show you in the next slide each one. It is quick and simple to use, minimal instruction required, translated into more than 35 languages, including Arabic, available free of charge, strongest evidence for use in children aged more than 7 years. In 5 years to 16 years, we have the color analog scale. It is 10 centimeter vertical scale with increasing gradation of color and width of signify increasing pain. Severity of pain measured in 0.25 centimeter increment. Strongest evidence for use in children aged more than 7 years. And at the last we have 11 point numeric rating scale NRS out of 10, starting from 0 to 10, and this usually in older kids 4 years to 18 years. Initially developed and studies for use in adult. It is the same numerical scale from 0 to 10 as we said, and classified mild, moderate, severe pain according to the number out of 10. Best evidence in patient aged more than 6 years. Here the flag, just in brief, it is 5 component: face, if no particular expression or smile, 0 and 1, occasional grimace or frown, withdrawn or disinterest, and 2, frequent to constant frown, clenched jaw or quivering chin, and so on. It is so its component is 0 to 2. We calculate 10 out of 10. This is the faces pain scale revised one. 6 faces: 0, 2, 4, 6, 8, and 10. And this is color analog scale, mild, moderate, strong pain according to the color, from blue to the red. And this is the 11-point numerical rating scale, 0 to 10. 0 is no pain, 1, 2, and 3 is mild pain, 4, 5, 6 moderate, 7, 8, 9, 10 is severe pain. Here we'll show the non-pharmacological intervention that commonly used for this type of patient, like breastfeeding, non-nutritive sucking, swaddling, facilitated tackling, rocking and holding, skin-to-skin care, vocal soothing, and tactile stimulation of alternate nerve fibers. We are commonly using this one. Olfactory stimulation, sensorial saturation. It's combining visual, auditory, and tactile and gustatory sensation. If possible, don't wake up the child just to do a painful procedure like cannulation. As children get older, explanation, pep talk, music, distraction, and child life specialists are invaluable to be used for these patients. Common pain management strategies we are using limit a painful procedure, let nurses treat pain, and they are usually better and more acceptable than doctors. Topical anesthetic like Emla cream to use before any painful procedure, and local anesthetic, nerve block, simple analgesic, opioid analgesic, low dose ketamine, although still controversy. Nitrous oxide can be used as well, like Antonox, and in more or advanced procedure we can do procedural sedation. When treating this patient, be cautious about the maximum dose. This is just to remind you about some common drugs we are using, like Imla cream maximum dose, usually less than 3 months. In less than 3 month patient, 1 gram on 10 centimeter square, about 1 fingertip unit, or a line of cream from the distal interpharyngeal joint to the fingertip. It is approximately 0.5 gram of topical medication. In 3 to 12 months, is 2 gram on 20 centimeter square, and 1 to 6 year is 10 gram on 100 centimeter square. The maximum lidocaine dose 3 milligram per kg without epinephrine, and 7 milligram per kg with epinephrine. 1% lidocaine is 10 milligram per ml. In small infant, you can reach the toxic dose very quickly, so make sure you do the math. This is the one recommend. He usually dilute 0.5 to give himself more valuable to work with this. Same for acetaminophen. In less than 1 month, 60 milligram per kg. In 1 to 3 months, 75 milligram per kg. So be cautious not to reach the maximum dose. For ibuprofen, it's contraindicated before 6 months of age, but is an excellent analgesic in older infant. Codeine in infant, in particular, there have been adverse effects because of rapid metabolizers, and numerous organizations, including recommendation by American Academy of Pediatric and Canadian Pediatric Society and the FDA and Health Canada, have warned against the use of codeine in children younger than 12 years of age. So it's not one of our choice. Fentanyl is a great option, but it might have altered pharmacokinetic in neonates with half-life up to 10 hours usually. So in general, neonates less than 1 month will require lower titrated dose, whereas toddlers, because of higher metabolism, require somewhat larger doses. We'll go over some common scenarios like abdominal pain. It's really challenging, and there is concern from the surgeon colleagues, and this is maybe the common one of the commonest presentation to emergency, and most of the time it is benign, but it can be if neglected can be serious. For mild pain, we can use acetaminophen as indicated with like 50 milligram per kg per dose, Q46 hour PRN up to 650 milligram. The oral route is preferred, but intravenous acetaminophen is an option for patients unable to tolerate orally, or for those in whom the per rectum route is contraindicated. For moderate and severe pain and those kept MBO, rehydration and volume repletion, a small frequent aliquot of narcotic agent. Surgical pain is not erased by opioid, to keep in mind. Treating pain improves specificity to certain surgical emergencies with retained diagnostic accuracy. If there is interdepartmental concern about prolonged effect, sedation or limitation in the physical exam, or there is a need to see if all pain will come back, you may opt to use fentanyl initially or for shorter half-life, and more frequent reassessment may be helpful in the with surgical team. Transition quickly to a longer acting opioid as soon as possible if the concern. Second one is long bone injuries like fracture pain should be addressed immediately with splinting and analgesia. Oral, intranasal, and intravenous route are acceptable depending on the severity of injury and symptoms. Consider an aggressive multimodal approach. Ultrasound-guided peripheral nerve block are good pain control adjunct, and it is really now new method can be used in emergency for adult and pediatric. Third scenario is skin and soft tissue. It's pharmacological, usually in addition to local anesthetic. For IV cannulation, consider Embla cream. Pediatric pain should be assessed carefully and treated aggressively. Submersion of the affected extremity in room temperature water if possible, or applying room temperature saline soaked gauze with both thwart ongoing thermal damage, soothe the wound and provide foundational first aid. Minor pain can be treated topically and with oral medications. Major pain require intranasal, IM or IV analgesic with morphine. Treatment may be escalated to ketamine if needed. Post-trauma disorder are common in burn. Effective pain management is ever more important in these cases. One of the important patient group is sickle cell disease in pediatric. I'm sure you are facing frequently, including usually treatment including intravenous hydration, oxygen inhalation, parenteral analgesic, opioid and non-opioid. And the use of oxygen is more controversial if patient saturating well. And the principles of pharmacological management of acute and chronic sickle cell pain are similar to those for managing any other group of patient. And non-selective and COX-2 selective non-steroidal anti-inflammatory drug are used commonly as single agent or in combination with other analgesic, including opioids. Mibridine is associated with sign of CNS excitability, including seizure related to accumulation of the normibridine metabolite. Given the effect of sickle cell disease on kidney function, these patients are vulnerable to this toxic effect of mibridine, which should not be first-line opioid for the treatment of acute or chronic pain. Emergency department guidelines for the treatment of sickle cell pain emphasize the need to evaluate patient quickly to assess and treat infections and treat pain aggressively. Some institutions have established day treatment hospitals for sickle cell patients so that pain management can be achieved efficiently by a group of clinicians who know the patient best. Substance abuse in these patients is a concern usually for emergency physicians. The prevalence of substance abuse disorder in sickle cell patients appear to be grossly exaggerated, especially if one considers iatrogenic substance abuse. One study demonstrated that hematologist and emergency department physician estimated that approximately 25% of adult sickle cell patients are addicted to illegal substances, when the published prevalence of addiction is actually much lower. In studies, they found no addiction found in 600 adults, and addiction only in 3, and dependence in 7 out of 101 patients, while suspected drug abuse in 9 and definitive out of that is only 5 out of 114. So the term pseudo-addiction has been used to describe drug-seeking behavior in patients who are provoked by inadequate control of pain. So I do believe this patient usually behaving pseudo-addiction more than true addiction. This one study, interesting study, I put it down, they collected patient over many years, and they found that patient too many intervention can be used, not only giving opioid or analgesic, which help significantly in decreasing the number of days in hospitalization for patients with sickle cell disease pain crisis by 40% over 5 years period, and to improve the care of patients with sickle cell disease. Here, just to show you one slide, one figure, this pre-intervention on the left side, and going on, they apply interventions gradually, over time, not all at once. And at the end, they found that hospital days has decreased in compared to October 2011, and the end of the study in February 2017, which is very important result in addition to other factors. I advise you to go over this study. So to summarize, in pediatric acute pain, know the child, know the family, and know the physiology. Use your observational skills enhanced with the collateral information to assess and reassess for pain in children. Treat pediatric pain well and often. Failure to address the child pain has long-lasting consequences. Non-pharmacological treatment for all, pharmacological treatment for many, and a multimodal approach is the most effective. Neonates, infant and toddlers, and school-aged children and adolescents exhibit specific physiology and expression of pain and the response to treatment. So tailor your regimen to your young patient physiological pitfalls and needs. Thank you at the end, and if you have any question, I can accept your question. Thank you.